14, and it's plantar fasciitis, but we will look into it straight into the summary.
Avi, is that the best way to go about talking through it, just to go through it step by step as a group? We should probably ask you. All right, cool. Just go with it and interrupt as you feel you need to, so we can all get the most out of it.
Yeah, everyone just jump in. I think it's basically this summary, this 2-page summary is just like it just goes through all the different levels of evidence for each sort of topic. So the plantar fasciopathy, the risk factors around it, which is B level evidence, a limited ankle dorsiflexion, a high BMI in non-athletic individuals, runners, work-related weight-bearing activities, particularly under conditions with poor shock absorption, and they're sort of the main risk factors. So you can have
Jack, sorry, just before we go on, sorry, Avi, just because Riley's new to this, would you mind just quickly summarising top of your head, because you know better than me, what the different levels of evidence mean with A, B, C, D, if that's right, just from your simple perspective?
A is like...
It's on the paper, but yeah.
Here we go.
We'll go to it. Yeah.
A is like the strongest level of evidence, so they're using like randomized control trials and stuff like that. And then B is going to be moderate evidence, and that is just using, I think, like one randomized control trial. I want this.
Yeah, a single one.
And then C is weak evidence. So, I should look this up because I kind of forgot.
Yeah, you can look at
it's a single. Yeah.
Oh yeah,
single level study.
Level 2. Sorry, single level 2 study, which is like not randomized control trials, other kind of studies usually.
Yeah.
And then D is conflicting evidence. E is theoretical or like based on animal studies, and then F is just expert opinion.
Okay.
I know we've sort of spoken about this, but is expert opinion F higher than like C, would you say, or like even
That's a really good question.
D?
No. Oh God, I don't know what I just did to my screen. Uh-oh, I don't know what happened to my screen, but no, like F level evidence is the lowest level of evidence because it's just an opinion basically.
So just an opinion with no backing at all.
Yeah,
that's right. We were asking then who is an expert? Are we expert? It's just our opinion. Surely that's.
I think they use like orthopedic clinicians like that have their OCS. I think.
So thanks for going over it. Just good so we all remember. Now, are you familiar with the CPGs?
Sorry, what does it stand for again?
Clinical practice guidelines. It's very, yeah.
Is this in reference to like where you're practicing? What the like?
I don't know. Avi, can
like kind of like golden standard?
Yeah, what's the background of CPGs?
So the APTA, like each section, so there's like the orthopedic section, they put out these clinical practice guidelines, which is basically like they take all the evidence on a certain topic, and once there's enough like research studies and evidence, they can make recommendations based on the evidence. So they put it all together in like one, the practice guideline, which is basically telling you best evidence for how to treat and how to diagnose, and they have all these different things for different conditions. So conditions that aren't well researched, they won't have a clinical practice guideline, but things that are pretty common do.
Yeah, that sounds right.
So,
yeah.
The Dutch have that too.
The Dutch have that too?
Yeah, they have the KNGF guidelines.
Oh, cool. Well, we don't have anything like this here for what it's worth. So I found these really helpful when Avi was here, and we went through a few of them, and they really helped in our decision around intervention and stuff. So I love going through these.
But in Australia, you guys have outcome measures, right?
Yeah, but they're just general. We don't like have a paper which summarizes the evidence like this. Yeah, with different levels of that. And we're taught research pretty poorly. I won't go into that any more than I need to. So yeah, sorry, Riley, you'll be able to see it as you go along. But yeah, cool. Let's go back to it. Come back to the start. But it was good just to go over so we're familiar about what they mean, and because I want to get some discussions plantar fascia is a very interesting case, and I want to talk about my clinical, not F-level evidence, I hope, but just my own background around how I've treated it in the past. All right, so
so I guess plantar fascia can affect athletic individuals, runners with high load, and also non-athletic individuals with work-related type high load. So people who are standing for long periods of time and whatnot. Diagnosis and classification. So these are some of the sort of symptoms. So plantar medial heel pain. So on the inside of your heel, underneath your heel. Most noticeable with the initial steps after a period of inactivity, but also worse following prolonged weight bearing. So worse after a bout of an aggravated activity, whether it be a long day of work or a long run, and also quite sore after a long period of rest. So even sort of after sleeping, the usual first few steps of the morning can be quite painful. Heel pain precipitated by a recent increase in weight-bearing activity, so that recent increase in load compared to the plantar fascia's capacity, pretty much. Pain with palpation on the proximal insertion of the plantar fascia, so that's sort of that in the medial underneath the heel there. A positive windlass test, so that's looking at the navicular drop test sort of thing.
Anyone else know what the
Yeah, it's like when we usually do it like standing with your big toe off of a step, and then you pull up the big toe to see if you have a windlass mechanism, and if there's no windlass mechanism, then it's indicative of, or if you have heel pain, I think that's a positive.
Yeah, it was both that drop, but also the heel pain as well. I'm just going to know the sensitivity around and specificity around that. But anyway,
negative tarsal tunnel test. So I guess that's a differing diagnosis. So no sort of, I guess, neural symptoms. Limited active and passive talocrural joint dorsiflexion range of motion. So a stiff joint. Abnormal foot posture index score, and a high BMI in non-athletic individuals, like you said.
Cool. Is there anything else you think, for those who have treated, is there anything else that you might be looking for when you're looking at a plantar fascia patient that wasn't on the CPG that we might have missed?
It's like passive stiffness in big toe dorsiflexion sort of thing.
I was just looking for that big toe. Same thing I was thinking about. Avi or Nat, do you have any thoughts about that big toe passive extension and plantar fasciitis and stuff you might have seen?
I mean, I've seen people that have less dorsiflexion of their big toe that have plantar fasciitis. You're asking.
Yeah. No, yeah, it was just if you've seen it, I guess, because it just wasn't part of that list. That's all. Yeah. That's all good. Yeah. Cool. We'll keep going.
Might come up here.
Yeah.
So differential diagnosis. We should assess for things other than plantar fasciitis. So plantar heel pain sort of encompasses a bunch of different sort of conditions, like fat pad atrophy, proximal plantar fibroma. So a bunch of others, and we should be, considering them when the individual's symptoms aren't resolving with the interventions that we're doing, and what we expect them to respond to the treatment. So coming into some outcome measures, we should use the foot and ankle ability measure. Here's a couple: the foot and health status questionnaire, foot function index. And the left's our favourite.
Our favourite. Thank you, Avi. Which one do you guys have a particular one you guys like to use with outcome measures for foot pain? Are you familiar with those, Nat, by the way?
I'm not familiar with any of. I'm definitely not familiar with the questionnaire and the LEFS.
So It was something that I learned at uni, but to be honest, you know, when Ivy came into an internship here, she really left her mark. And what we started doing with initials is linking an outcome measure to an initial assessment. And the lefts we just found super helpful to just, you know, have a good baseline measure for where those injuries are. So I suggest when I give you this paper, go and have a look at them and just see. Questionnaires are a great way to help determine long-term outcome measures. Just quickly on that, Avi, how else have you found those questionnaires helpful for the client journey and stuff like that from your point of view, since you've been using it longer than us?
Well, I think they're a pretty good way to see, like, they take like functional ability into consideration rather than just pain. So you can kind of like show a patient their score and how much they've improved. And I think all of those should have MCIDs for them, so you can actually see if their like changes are significant or not. But I think it's pretty cool when a patient can like see on a piece of paper that they've actually have made improvements, even if they sometimes don't feel like they're always headed in the right direction. Overall, it kind of like gives them a good idea of where they're at.
Yeah, couldn't agree more. And what I've been trying to do here is move away from pain and more to function. So I just found like things like that. And we need to, Jack, and Riley over there, we need to actually do this more with our new patients as we've got them busier, is, you know, help them focus on that. Because a lot of the time we know on a journey, pain might not come down straight away, but function can improve, and we need to help communicate that, you know, to the client. But yeah, have a look at that, reference it later. Definitely worth looking at. Cool.
And here's for some F-level evidence for activity limitation and participation restriction measures. We should utilize easily reproducible performance-based measures of activity limitation and participation restriction measures to assess changes in the patient's level. Yeah, so it's just we should use more outcome measures.
That's fair, but yeah, that's why
that's fair. On examination, when evaluating a patient with heel pain over an episode of care, assessment of impairment of body function should include measures of pain with initial steps over a period of inactivity and pain with palpation of the proximal insertion. And may include, so pain with initial steps, pain on palpation of the proximal insertion, and then including measures of active and passive dorsiflexion range of motion and BMI. There should be a full stop in here somewhere. And BMI index.
Well, that makes sense, of course. Yeah,
it makes sense. Yeah. Cool. So onto our interventions, the fun stuff.
Manual therapy, A level. Oh my goodness. Let's look at this.
So we should use manual therapy consisting of joint and soft tissue mobilization procedures. Procedures to treat relevant lower extremity joint mobility and calf flexibility deficits to decrease pain and improve function in individuals.
Holy crap!
A-level evidence in these sentences.
Yeah. What do we think?
Yeah, A-level evidence.
Rightio. Open floor. Anyone have any thoughts? We'll put them all together. You know, manual therapy, stretching. We won't get into the taping and filters just yet, but they go hand in hand. Do we agree?
Yep.
Disagree? What do we think?
A-level probably came with a bit of a shock, but
yeah, Adam Meekins eat your heart out.
I don't have a problem with it.
Yeah. What do we think? What are we thinking, guys? Do you think? Yeah, I just want to get people's thoughts about manual therapy and helping plantar fasciitis. Oh, don't all go quiet at once.
Not a shock to a decrease.
This article was in 2014, right?
Yeah, but it summarizes sort of all the evidence that's out there.
It's a literature review.
I don't know how they work
pretty
exactly.
much.
It's more than a lit review.
Yeah.
Oh, well.
Yeah.
Yeah, I mean, that's pretty good.
Yeah.
Yeah.
Absolutely. It's the highest level evidence paper you can do. Do we agree with it? You know, do we think manual therapy is A-level? I'd be very interested if you don't agree with it. I just want to know. Avi, what are you thinking? You're staying quiet over there.
I think it's fine.
Yeah.
Sure.
Yeah. It's just so interesting because this is in 2014. In 2020, I'm just seeing so many people so anti-manual therapy. It's nice to see some actual evidence for it because I do believe it.
Yeah.
I wonder if there's more of a psychological component to that, because, for example, when you're doing manual therapy on someone's back, they can't really see it. But when you're actually working on their foot, they can visualize it.
Who knows? You know, I think I would love to see the specific studies around it in time, but I think, like you said, they summarized it really well, consisting of joint and soft tissue mobes, procedures to treat lower extremity joint mobe calf deficits. You know, you're looking at the deficits. I'd add in there kinetic chain. I've treated a lot of plantar fasciitis conditions really effectively by looking up the chain at your knee and the hip as well, because we know with biomechanics, sometimes it can affect the whole kinetic chain. So that's something to keep in mind. But yeah, really, really interesting. The second one, though, I find really interesting, actually. Clinicians should use specific plantar-specific stretching for pain relief, and heel pads may be used to increase the benefits of stretching. What do we know about the mechanics of the plantar fascia and stretching it? Anyone?
Isn't it they're starting to recognize it as a sort of a tendinopathy these days? So
yeah, that's exactly what I was going to.
Stretching is a little bit of a, I don't know. I just know that I think since this came out, there's been a lot more of a focus around it. Could be like treating it like a tendinopathy, so a lot more like strengthening stuff and less stretching.
Has anyone else heard about that? Avi, Nat, have you heard about the mechanics around straightening versus stretching of the plantar fasciitis with rehab?
I think I've heard about it, that concept with other parts of the body, the strengthening and stretching. Cool. But generally, that's kind of what we start with. We stretch before we strengthen. So, yeah, it's definitely something to consider.
For sure.
To learn more about, I think. Yeah.
Avi, we gonna add something?
No, I don't think so.
No? Can I ask you a question? Someone walks through the door, you're working in clinic tomorrow morning, and they have a plantar fasciitis that you've diagnosed. What sort of things would you be looking at in their initial round of exercises in that first session that you give them to take home?
It depends how flared up they are.
Good, yes.
But definitely some calf stretches for gastroc soleus, a ball to roll out the bottom of their foot, or like a frozen water bottle. It's also a good one.
Like that one we've got in the back room, that's better than a ball.
Yeah. Yeah.
I don't know what you're talking about.
Sorry, Nat, there's this roller that's amazing, but Avi's the only person
who
doesn't like it. Yeah.
You guys ever give these patients more stuff to do with their feet as well? Like,
yes, Nat. Foot intrinsics, I think, is so important as well. But what I wanted to say to what Avi was saying is that when you look at more modern evidence with this stuff, don't throw the baby out with the bathwater. Sorry about my Australian phrases for you on a Tuesday night. There is still great evidence that stretching and a bit of manual therapy can help set stuff up so you can load them correctly, I believe. And I'm sorry if that's F level evidence, but according to this, it's A, so that's good. Because a lot of modern day evidence of plantar fasciitis it's a tendon issue. We've got to strengthen. We've got to do isometrics. We've got to go. But if you don't have a good baseline, if you don't look at, calf endurance, say they're a runner and they don't have good calf endurance, if their glutes not firing, if they're tight through different regions, they, like what Avi said, look at that kinetic chain and work through that. It's just, I'm glad this came up, because if you look at modern day evidence, that's all they're saying. Have you guys heard of the fasciitis spider? Either of you? Any of you?
Oh, yeah,
no.
yeah.
So it's just a way to load the plantar fascia. We're probably going to get one for that reason. You can look it up after. But does that all make sense? I think that's really important. Don't when you're treating this, look at all the impairments. Don't go straight to strengthening necessarily, I think. But yeah, happy to be proven otherwise. Cool, Jack. We'll keep going.
And And on that note, we'll go into stretching. Clinicians should use plantar fascia specific and gastrocnemius soleus stretching to provide short-term, a week to 4 months pain relief for individuals with heel pain / plantar fasciitis. Heel pads may be used to increase the benefits of stretching.
1 week to 4 months. That's an interesting time frame, isn't it? Anyway. Sure.
If it's not working after 4 months, stop it.
Yeah. If you're still only giving them stretching after 2-3 weeks of treatment, you probably want to look at something else as well. But anyway, I'm happy with that.
Yeah.
Keep going.
Move on. So taping. Should use anti-pronation taping for immediate up to 3 weeks pain reduction and improved function for individuals with heel pain / plantar fasciitis. Additionally, clinicians may use elastic therapeutic tape applied to the gastroc and the plantar fascia for short term. 1 week.
A-level evidence for kinesio.
Yeah, A-level. That's crazy.
Really? I've got to look more into this. That's so interesting. I've never seen something, everyone's so anti-kinesio tape. That's what I assume. Would you guys think elastic therapeutic tape is just kinesio tape?
I think so.
Yeah, I would assume so.
Interesting.
For 1 week.
Yeah.
1 week is
all right, I'll give it a crack.
Stuff is rigid, so sounds like it.
We'll move on. Cool.
Into foot orthosis. A-level evidence. Clinicians should use foot orthoses, either
It's
prefabricated.
Like
Yeah. We haven't need exercise.
Just do it all.
Either prefabricated or custom fabricated / fitted to support the medial longitudinal arch and the cushion the heel in individuals with heel pain / plantar fasciitis to reduce pain and improve function for short term, 2 weeks, to long term up to a year, especially in those individuals who respond positively to antipronation taping techniques.
Wow. Okay. Have either of you taped much with this? Did we tape any plantar fascias while you were here, Avi?
I've done it before, but I don't know if we did it there or I don't remember.
But that's right. But you understand the point. Yeah, you definitely feel like tape. How long would you? I know you're going to say depending on the condition. Would you say pain modification and settling? Is that how long you would generally tape for in your experience?
Yeah, I feel like people when they come in for plantar fasciitis, it's because they have a pretty bad flare-up. Because I feel like usually, at least a lot of the patients that I've seen don't come in like immediately. They come in like months later when it gets really bad. So I think it's helpful for pain reduction so they can kind of walk normal and get on with daily life stuff.
And as you can all see, they're all, these imperenches are temporary to help modification. Then we've got to build the strength after that. But I'm interested to see they're all A-level, so interesting. Night splints.
Night splints, A-level. Should prescribe a 1 to 3 month program of night splints for individuals with heel pain who consistently have pain with the first step in the morning. So, targeted those people who have morning pain.
Cool. All right. I've never used that.
Very interesting.
Might consider it. All right, here we go. All right.
So
you use those a lot for carpal tunnel, so I guess it's like
same principle now. I think so.
Same principle,
So
there's our
electrotherapy.
D-level. There we go. Now normality has set in.
Clinicians should use manual therapy, stretching, and foot orthoses instead of electrotherapeutic modalities to promote intermediate and long-term improvements in clinical outcomes for individuals with heel pain. Clinicians may or may not use interferosis.
Iontophoresis. with dexamethasone or acetic acid
is
to
that
provide short term.
What?
Is iontophoresis a thing in Australia? Because I never saw it any time when I was there.
I don't think so.
I don't think so.
I've never seen it in the US either.
Yeah.
I want to talk about, have you guys seen shockwave therapy? Either anyone? Riley, have you heard of shockwave therapy, by the way?
I've heard of it, but I
Yeah.
couldn't tell you what it is.
I'll tell you. Avi or Nat?
We had it.
Yeah. On Jack, sorry, you go.
Yeah, we had it at the practice that I was at before.
Yeah.
And they used it, and they, a lot of people were finding that it helped. My mum swears by it. It's the only thing that helps her plantar fascia.
There you go. Avi?
What is shockwave therapy?
Oh, we got to find it. Yeah. Electrical shockwave therapy. So it's literally, it's not electrotherapy, which I would suspect is more like inferential. It's applying targeted shocks to the plantar fascia. Now, I had access to one 2 years, or longer than that, a couple of years ago when I was working in the city, and it used to just nail people with plantar fasciitis, but I still don't fully understand the mechanism. And my understanding is that there is some really good evidence coming through that it is effective. So I highly suggest you look it up. Jack, can you just write that down, and we'll send it to Nat and Avi when we find some evidence for it.
And it's used for like chronic, chronic?
Just in general, shockwave therapy, which we can talk about another time, but tendon issues apparently work really well. From when I used it clinically, I found tennis elbows that didn't help too much, but Achilles, plantar fasciitis really worked well. Maybe the bigger tendons, I don't know why. When I got it, we were one of the first people to have it in, it was just coming through in Australia. So I was just using it on everyone because I could. But it's called ES, electrical shockwave therapy. So you can look up ESWT. It's not inferential. It's very different. And there is a moving evidence to suggest it actually really works. But I still don't fully understand the mechanism by how they suspect it works. That, we used to say, it promotes blood flow to the area or something. And I'm like, I don't really believe that. I'd like to have more of an understanding, but I definitely want you guys to look it up because it's, it's come out in the last 3-4 years, and a lot of reputable clinics are using it. And it's interesting that neither of you have heard of it. So have a look it up and see.
So low-level laser, clinicians may use low-level laser therapy to reduce town. There you go. C-level. What's C-level again? Weak evidence. Weak.
Come on, guys. There's no way laser
not even
is going to help.
It's just weak.
No.
Phonophoresis.
Study.
Ultrasound. Here we go. Now we're talking.
I've seen that used a lot.
Yeah, I'm sure.
Ultrasound cannot be recommended for individuals, and that's weak.
Then why is it still C?
Or it's just weak. The evidence behind
it. It's saying that you can't use it.
Electrotherapy is still higher for a little.
Yeah.
Sorry.
Yeah. Anyway. Keep going, that makes sense. Cool.
So some footwear to reduce pain with individuals. Clinicians may prescribe a rocker bottom shoe. Construction in conjunction with foot orthosis and shoe rotation during the work week. So people who are standing long periods of time in their workplace, they should sort of rotate their shoes around. So education and counselling for weight loss is a E-level evidence, apparently.
Okay.
So, that's a bit of a shock, I think. We may provide education and counselling on exercise strategies to gain or maintain optimal lean BMI, and heel pain / plantar fasciitis. Clinicians may also refer to individuals to appropriate healthcare practitioner to address nutrition issues. And then we've got therapeutic exercise, expert opinion. We may prescribe strengthening exercises and movement training for muscles that control pronation and attenuate forces during weight-bearing activities. Interesting.
So hang on. That's not saying strength training's F, is it?
Yeah.
Am I interpreting that right? You can't agree with that, can you?
So. Yeah.
Avi, you want to help us out here? You believe in strength training for plantar fascia, right?
Yeah, I think it's just the amount of studies that they've done on it.
At that time.
At that time, yeah. So this is, I think that there's been another, maybe a lit review since, I think, from last year. I want to say, I was trying to look it up.
Yeah.
So I think maybe since 2014, it's changed a lot. But even then, that's not that long ago.
Geez, yeah, that's really interesting. I was always doing calf raises and stuff for that, even when I graduated in 2011. So yeah, that's interesting. That's why it's really important to discuss and interpret it. You can't take it in totality.
There you go. This is based on scientific literature published prior to January 2013.
So just something to keep in mind.
Just says here. Yeah,
so by the way, electrical shockwave therapy didn't exist prior to 2013.
Yeah.
So you should definitely look that up.
Oh, wow.
It'd be interesting to see.
Yeah.
They need to upgrade this.
Yeah, if they're updated, please let us know. Because these things are so good. I think that's all we need to say, really. So that's the summary.
Yeah.
Cool.
Well,
so
what I'm wondering is with the neuromuscular education and exercise, if we're saying that most of this is caused by overuse, then I don't know. I guess like doing those other passive approaches seem to give the tendons the ability to kind of heal up and rest. I don't know.
It's good this is Sean, because this is what I want from these journal clubs, is I want discussion points, because a lot of the A-level evidence kind of conflicts with my philosophy around physio. Not massively, but just in terms of we want to empower people to educate them to solve the problem. So you can't tell me just passively stretching and relying upon manual therapy is going to fix a plantar fasciitis. So that's what I just find interesting about if you interpret it just on a surface level. Obviously, as you read it more, you can see where it's coming from. But, when you look at that neuromuscular interventions, being overweight can certainly contribute to plantar fasciitis. And, it's something you should,
I guess you have to take everything in here with a grain of salt and really apply it to each person's what's going on.
I think that was always the vision of a journal club. So you can actually tear it apart and interpret. And that's why it's so good to have you all on here so we can discuss that. Because even for me, I'm like, cool, like there is still a lot of evidence, even though it's 2013, like around the passive things, but it can't be the be all and end all. And I suspect if we did this now, there'd be so much more evidence for loading and movement. And we double down on education here, Nat. We're very big on trying to make sure we give people the tools. And I think that's so underestimated. It's harder in America with the systems you have. And particularly when Avi was here, we had some great conversations around how she would implement what we did there. And it's just not practical with insurance and things like that, to be honest, to see people say 5 times in 2 weeks and not do as much hands-on, because they'd just be like, so my deductible is gone for the year. Great. Now what do I do? So it's an interesting, so you got to put it in perspective, but I guess interpret it, as you see fit. Do you have any take-home message?
It depends on the setting you're going to, because after I had my ACL in the States recently, like there was 0 hands-on. It was all just exercise. And it was a hospital outpatient setting. So maybe because it wasn't in a private practice, there wasn't this idea that, oh, well, where's my ultrasound or where's my, electrotherapy? So.
And similarly, in some of those hospital settings, they can get way too passive and they'll literally just electrotherapy and ultrasound you, and that's it, which we obviously don't agree with. So, that's interesting. What's your?
It depends where you are.
Yeah. What was your take home, Avi? Interpreting all that information
from the CPG.
Yeah, just if you want to put in a nice bow,
Oh man, my take home.
Yeah, putting on the spot. That's how I roll.
Just treat the patient's impairments. Like, I mean, I think a lot of it's like pretty like self-limiting dysfunction. So if you can reduce their pain and increase their function, like by whatever means you can,
do it.
That's fine.
I totally agree with you, and I think when I look at something like that, you treat what's in front of you. Like Avi said, plantar fasciitis can come by being really acutely flared up and sore to barely okay and need loading and movement. So you got to see where they're at in the journey. If they're early in the journey, you may need to tape them up, be a bit more passive, settle things down, get them going. But we also know that settling their pain is not, this is most important, which I know you all believe in, that's not fixing the problem. Because you settle their pain and they start loading it again, what's going to happen? The pain's just going to come back because they don't have the right, mechanics to deal with the load. So I know you think it's simple, but I think it's important, Avi. Treat the person in front of you and deal with the objective measures and deal with what was the word you used? Deal with deal with what's limiting them. What's in front of you. I love it. What about you, Nat? What was your big take home?
From this particular CPG, I mean, it would have been nice if they. I think it would have been nice if they took through different phases of recovery, but I guess that's hard to do. So many
CPG,
so many components.
Some of the CPGs do that, which is kind of cool.
Oh, nice.
Because then in that case, I think it would be interesting to also see, like you said, I was like through each phase to see what type of intervention is most effective, or like what's based on the evidence. But
love it.
It's interesting to see like how they rated everything, and definitely was kind of surprised to see some of those in the A category.
Yeah, that's for sure. Absolutely. Thank you for that. Jack, what was yours?
I think it's just how, there's still some great evidence out there for manual therapy, which is good to see. But I think just, taking out of this sort of CPG, nowadays it is treated much like a tendinopathy. So, depending on where, how long the journey they are, I still believe in a big part of it is just educating that, this tendons take a long time to heal. This could be a long sort of process, but the main sort of thing is all about that loading and trying to get that right in between level of loading, and then increase their capacity from there.
Yeah, no, I love it. And Riley, at the end, having not known my news, did you learn anything new that you'd like to share with the group?
Because I don't really have much of an understanding, that was just so much information, so I think I'm just still trying to take it in, kind of. But yeah, it was just interesting to see what they regard as like kind of what you should do and what you shouldn't do. So yeah, that's really.
And you'll see more, and I'm really enjoying these journal clubs, and
these are good.
These are really good. We can
look at on page 17. There's shockwave therapy.
Oh, what?
Update.
Keep going.
Oh, it's in there.
Yeah, that's one of the articles they used.
Cool. Let's go down and talk about that before we finish up.
Sorry,
there
that was
you go. No, I'm glad you found it before we wrap this up. There we go. Yeah.
Does not appear to be more effective in reducing pain than stretching and therapeutic ultrasound.
Well, that has definitely changed. So
it's no worse either. So
yeah. I'm going to challenge, if anyone can find me some evidence on that before next week and send it around, that'll be great, because I know that's changed. There's so much more.
Plantar fasciitis.
What'd you say, Nat?
Therapy for specifically.
Yeah, definitely specifically for that, because I used to use it all the time on it. But I don't know, I still don't understand the mechanism by how it worked, having done it for so long, which tells you something. I know the proposed mechanism, but I don't really believe it. So yeah, cool. I'll just stop recording. Thank you, guys.